This is just, we're going to try to get into a practice of just having open forum discussion and debate brought back into medicine, and where we can feel comfortable with our colleagues if there's anything that is pressing that you have. So there's a couple things I wrote down. If nobody has something that do you have something already? Why don't you start? I'll only add if we don't fill in some stuff. Go ahead.
Okay. And so I think that in 2023, the separation of religion and medicine needs to continue to be maintained. And I just have great concern about the homogeneous nature of our legislatures, the lack of diversity in thinking and voting, and how it's going to affect our patient care. And I don't think that that is an extrapolation based in some weird theory. My position on abortion for myself or my family doesn't have anything to do with my patients. And it just gives me great pause and concern over abortion legislation in Tennessee and how that's discussed, and legislation related to gender in Tennessee and what I see in other states. And so just as an organization, I don't know if we had an opportunity to provide input on that. And if we didn't, is there a way that we could do that?
You're talking about TOMA specifically.
Yeah. We have input on insurance and whether or not nurse practitioners should have full practice rights. I think we should be able to sound off whether, collectively, if there is an opinion or not, the doctor-patient relationship on things as sticky and as uncomfortable to talk about as stuff like that.
Yeah. Does anybody else have an opinion on the legislature in Tennessee and that, what he was talking about?
If we can't talk about abortion, we can't prevent it. We can't give them other options. We can't find other things for the person who is just terribly frightened and doesn't know what to do. And no matter which way you feel, if you can't talk about it, you can't solve the problem.
Yeah, as some of you know, I'm an obstetrician gynecologist, so this issue has been very pertinent to me. It's one of those things that I don't actively do elective terminations in my practice, and even before the Dobbs decision did. But what it seems to me is it seems like we have just a complete, just our society, or I don't know if physicians we can do more about that. But I remember when I was in elementary school back in Des Moines, Iowa, we started sex education at like 5th grade, and the girls went in one room, the boys went in the other. So there was at least seemingly like a societal input on how to teach sexuality, and because not all of us are the same. Other families talk more about it and other things, but that we've seemed now to care more about issues that are just, I think, just really, really disappointing as a society. And I think, if we can open a dialogue with that, but I don't know how we do that because there's so many things going on. But the issue from the General Assembly, I think, was, and in other states, is kind of just very difficult for a lot of patients. I think what I get most worried about is that what's going to happen with the abortion issue or elective terminations is that, well, it's going to spill over into other aspects, because usually when people, I can always, I can try to see both sides if they're against elective terminations. But on the other hand, if they say, well, we need to stop IUDs or we need to curtail contraception, then I stop listening, because then there's illogical thinking there, because the only way you can stop unwanted pregnancies is through adequate birth control. So I think there's issues we can try to push with a physician, but as a physician, but I just think it's just disappointing. And I don't know. I think it's a scary thing when, if I do a procedure and then someone thinks I do like a suction DNC, and then if the anesthesiologist or scrub tech wants to turn me in because they said I did an elective termination, then I'd have to prove myself innocent. I know Governor Lee has signed some few exceptions, so hopefully that'll help a little bit. But it's frightening when you can be thrown in jail and you have to prove your innocence versus other things like that. But just my thoughts, and that's it.
We have to remember that our elected officials are not necessarily educated about the things they're voting on. Many times they don't even read the bills. It's up to their staff to tell them what to do. So part of our job is to educate these people about what they're voting on and the unintended consequences of what they're voting on, which is what you're talking about. And it's not just the abortion issue. It's across the board on everything. And you also have to remember that the single motivating factor in these people who are voting, majority of them, is re-election. They're going to do whatever it takes to keep them in power. Not necessarily making sense, not necessarily even thinking about what they're doing. But if the right person tells them the right thing to vote, then they're going to do it. An example of that is Tennessee was the last state to ratify women's voting. Do you know how that came about? The mother of the one last holdout told her son, this is what you need to do. So he voted for women's rights. That's how finely influential a single person can be.
Anybody else?
Are you still attending topics?
We can, yeah.
In my observation through about 40 years of practicing and being within this, and many of you, most of you understand this, is that we don't necessarily treat each other the proper way. If you were raised in a small congregation like I was, you heard the golden rule. You treated each other the way you wanted to be treated. And unfortunately, I think when we get into medicine and medical groups, whether it be a residency or whether you're a senior partner, that we don't bring that all the time to our practice. So often, the number one item is from finances. You want people to get in there and help you and do your work for you, but you don't want to give them the extra money for it. You want to keep as much as you want to as long as you can. So the way we treat each other, whether we eat our young or not, is something that needs to be discussed.
Let me add something to Paul. I grew up in very rural Georgia. I had a grandmother, had aunts, uncles. I was taught to say, yes, ma'am, no, ma'am, respect her, yes, sir, no, sir, respect your elders. I got old enough that I could outrun my grandmother. So I sassed my grandmother one day. I didn't count on my aunt running me down and beating my butt, and you do not backtalk or sass your grandmother. And I didn't backtalk or sass. That was a good rule. The point I'm making, I had grandparents. I grew up, didn't have a lot, but you had a loving atmosphere and parents that you cared, grandparents, aunts and uncles that you knew cared, and I don't think it's like that anymore. When I went to high school, if we did something out of line, you got your butt beat, and when you got home, you probably got it beat again. So a lot of it is deterioration of the founding principles of our country. And that's directly what it is. I'll be 85 in October. And my grandmother fed me stuff made with grease, bad flour, salt pork, because we didn't have refrigerators. It studied my age.
Yeah. I think being exposed to a lot of rural Tennessee, there's still a lot of that out there in mentality, which is really great. And the rural hospital closures in those areas have really hurt the rural areas, and a lot of stuff has been pushed through the cities. But if we think about small victories that can be made as people are trying to work to revitalize their clinic and practice and to have a voice and things we can get together on, is you'll have providers coming out who are out of their residency, who haven't gone through all of their credentialing for insurance companies like Medicaid. And to think right now that with us being an MCO state here in Tennessee, that a newly graduated licensed physician who hasn't completed his Medicaid credentialing cannot write amoxicillin for a child's ear infection just doesn't make sense. Like, if you take that prescription down to the pharmacist, they try to look up that new grad and they say, oh, well, we found your license number, but you don't have your Medicaid credentialing. So we're not going to fill this prescription for this ear infection for the child. And then in a big city, maybe, or a place where you got other providers around, they can go hunt around and try to figure out somebody to do it. But it seems like a small thing, but with people moving around, the graduates and everything else around, it seems like we could just go and say to the legislator, look, it doesn't matter, a prescription's a prescription, and if a child has an ear infection, they shouldn't be able to deny filling a $4 or $2 prescription just because the physician hasn't completed their Medicaid credentialing yet.
And to me, also, where's the law that we have to be under Medicaid or Medicare? I mean, I'm a cash-based physician to begin with, so to me, that's frustrating to hear. I didn't even know about that, but I've opted out of Medicare also, and I've struggled, and I don't play the game with them, but they will not allow me to write a Medicare patient for certain things like home medical equipment and things like that, because I'm out of Medicare now. So that, I have my DEA, I have my license, I'm double board certified. So how is, me being under the government certification, or the, signing up for Medicare or Medicaid, which you were discussing, how does that have anything to do with what I am allowed to do as a physician? I thought that licensing and DEA had everything to do with that. So I feel that, and that's frustrating, and I think there should be some legislation to kind of pull us away from that government bracket.
Yeah, just to follow up on that, on our experience, we've had providers who are just like you. This is in West Tennessee at a rural hospital. My company owns and operates, where the payers will not pay for the test. So if you write a prescription for an outpatient CT and they have Medicaid, or if they have Medicare and you're not credentialed, and your name goes on the hospital bill that goes out to the insurance company, the hospital will not get paid either. So you're not getting paid for your services unless you have a cash business, but then the hospital doesn't get paid either. And it seems like we should be able to get together and say, when it comes to some of these things, a prescription's a prescription. Now, the way that we deal with a lot of those things is we have agreements with doctors like you, and that one of our clinic doctors will come over and concur very briefly and do a quick note and write the prescription, because of the cash-based doctors around us. They can't get tests done, but still we got to take care of patients and make sure they're getting their diagnoses that they need. But it seems like from a legislative position and from an organization's position, you should be able to go into the statutes, at least for Medicaid in Tennessee, and say anyone that has a license is default. The patients will have their prescriptions and testing and hospitalizations paid for. And that's I think that's something that's an easy win, and it would be something really good to get behind.
I think we could also link that to the access discussions. We were, the NPPA was one of the things on my list. We were discussing yesterday or the day before about them going for independent practice because, we don't have enough access. But, those laws like that are limiting access to, rural areas. So I think that's kind of an argument we could throw into that discussion as well. Anyone else? Yeah.
I'm not sure how we did it, but about 11 years ago when I had my solo practice in Woodstock, and I had a very small office. It was kind of like in a warehouse, really. I mean, the front office was small, and then I had a back part that was just open. And I was with GOMA, Georgia. I decided to try to get some of the politicians to come to my office and have a dinner, and some of the physicians in GOMA, and just have a talk about, all of our concerns of what was going on. And so one of the fellas that had some contact with some of the politicians, and Holly, she was the secretary of GOMA, she took care of some things, and then I took care of the drug rep, bringing in food, and we just got that back part of my office with linens on the tables and lights, and made it a little restaurant, more or less. And we had several politicians come in and sit with us and just talked about our concerns, and they were very open to listening to all of our concerns. It was wonderful, and they really remembered what we talked about. So I don't know if that's something that we could do. I mean, that was about 11 years ago. But, if anybody knows anybody politically, that, because they were very open to listening to us.
I think the doctor of the day, yeah, Tim's been talking about, the doctor of the day as an option for that, because he does that pretty regularly and goes and meets with the legislature. So he's always asking for volunteers. So if anyone is interested to bring up some of these ideas directly face to face, there is that already set up. And you said it's monthly while they're in session, correct?
The doctor of the day is during session, and we have one day designated for DOs, which is a Monday the past 2 years. But Betsy can set up an appointment with your representative, your senator, anytime you want. And you can email and you can call. I'm saying it's best to put a face with a name. So if you have an opportunity to take a trip to Nashville, have Betsy set up an appointment for you. That gives you 15 minutes or half an hour, whatever you set the appointment up for, to just have a discussion about whatever you want to have a discussion with your senator or representative, because you are their constituent and they love to have visitors. They love to show you off. They love to know that they are talking to their constituents, and if you have a legitimate concern, they'll listen to you. And whether anything will go from there, it just depends on that relationship.
When I moved to this state in 1988, when I retired from the Army, within 3 weeks I was invited to be a member of this organization by then President sitting in the back of the room, a classmate of mine. I discovered, and I came and became a member. At that time, it became apparent that there was still, in 1988, which we thought we had progressed quite a bit, that there was discrimination in this state against osteopathic physicians. For example, around in this area, unless you were a member of the medical society, you could not be on some of the hospital staffs. You could not get privileges. To be a member of the medical society, you had to be a member of the TMA. The TMA did not approve osteopathic physicians having being members at that time. So within 2 years, this organization effectively got a single bill passed through that eliminated discrimination against osteopathic physicians. We did it. That's one of the things that we did. That was important to do that. And you couldn't do sports physicals on high school kids because you weren't an MD. And that was in a rule in the state. And that didn't get changed for 5 years of us fighting it until the chair of that committee got off of there. Because what they stated was the only individuals that could do it were those licensed by the Board of Medical Examiners. We were licensed by our own board since 1906 and still are. But once that guy was out of there, we got that changed. And the reason for that, they had a hell of a battle when chiropractors were pushing to be able to do sports physicals. And so they told, and my partner and I have been doing physicals on high school students. We did them in our clinic for $5 and would go to the schools. But he told us we couldn't do it because someone came down with that rule and it was there. But we got past that. My point is, this organization is one way to help effectively influence legislators. We cannot do it with 135 members out of almost 2,000 osteopathic physicians in this state. One of our crises is we have to we need to hear all the voices. They're not in here. And we need to figure a way to do that, to have a significant number. When you go in, you have to have the numbers. We are getting more numbers. We're about to get our third osteopathic medical school in this state. And we are going to grow. We are growing. But we need to figure out how to do that. And we need to do the things like, because how many people are you going to get to volunteer out of 135 to go and talk to a legislator when you're worried about practicing and getting everything done that you need to do at this time? So that's a crisis issue with me and at the national level and at this level. So we need to work on that and have a given way to do it. If we're going to address the legislature, is it something we all, or the majority, agree that we're going to be in there? Are we representing me? Or am I representing osteopathic medicine in this state? And when we work with TMA, like we have started doing, and they're working with us, we're still the minority, but we should speak at the legislative level when we can with a unified physician voice. That's why that's important to have the dialogues that we're now having with and working with the TMA, because we should speak for all physicians on these significant matters when we're talking about alternative providers and everything else. We should be in concert, and we should all agree that we're in concert before we open our mouth. But we've got to protect ourselves. Those are just a couple things that always have bugged me.
Thanks. Not a one of you in here know me. My name's Sheldon Weichel. I'm from Ohio. I come to this meeting because you beat the crap out of the Ohio conference, which was last week, and I attended there. One of the things, your doctor of the day, one of the things that we've done up there is get the legislators to come to us, in that we hold a town forum like this. And last week I think we had 250 in attendance, something like that. And then they did it virtual, and there was another couple hundred online there. But we, 2 years ago, 3 years ago, we had the Speaker of the House, Speaker of the Senate, and the governor all sitting up front. And I think that might be something that y'all could look into trying to do, and you have connections where, right, where you might be able to get some of the higher echelon individuals to come and sit and listen to you, so that if there's only 135, they still hear from 135 people, and not, with no disrespect intended, not just one person at a time or two people at a time or something like that. Yeah. No. I'm. Well, if I could get my wife to say yes, I'd be moving here tomorrow, and I'd be happy to be on your committee. Trust me.
Tell her we'd love to have you here.
I'd give a shout out for Doctor of the Day. Because of COVID, I haven't been able to do it, but had done it for many years. And you get a free tour of we've got, one of the oldest state capitals, and you get a tour. You get to see where, it was overran by the Confederate soldiers, and bullet holes, and history, and it's very interesting. It's a beautiful place if you've never been there. You get to meet your representative. They announce you from the floor. They recognize you. They put you in the records. It's fun. I mean, it really is. And the ask is very little. If they bump their head or somebody comes for a Band-Aid or something, is very little. I had one of the famous ones pass out one time, so that was a big time, and an ambulance was actually called. But otherwise, it's pretty much just a chance to meet one-on-one, and I think that's a great idea to have a forum, because they want to hear from us. I mean, we have a lot of influence in our communities, and they want people who have influence on their side or to be on our side, and they just need to know what it is. Nurse practitioner issue and the PA, that's getting to be more and more, and there's less and less. The federal government has approved that given independent practice, if you have a nurse practitioner in this state, if they're working at a VA, they can be independent. It's already there federally. And so, the nurse practitioners, the argument is, and you heard it the other day, is that we're not saying we're against PAs or NPs. It's that we need to be captain of the ship. We need to be the director. And the statistics that speak to that are the fact that there's not a decrease in health care when you have NPs and PAs, because the lack of extra training makes it difficult to make a decision. So when I have a chest pain come in and I talk to them and I realize, well, that's epigastric, that's just GI, I don't have to run a million other tests or anything else. I diffuse the bomb in a sense right there. But they don't diffuse the bomb. They don't have the confidence, unfortunately, because of the lack of experience. So they statistically are much more likely to say, oh, you're a chest, you go to the cardiologist. Oh, it's your ankle, you go to the orthopedist. So when you look at the cost to care under nurse practitioners specifically, it goes up. And that's the argument that is recognized and heard, is that it isn't going to help healthcare. Plus the argument that the NPs make of, we need to help rural medicine. You don't understand, rural medicine is screaming for us. But then you looked at disbursement of where they all practice. It's Nashville, it's Knoxville. They have almost or very, very little percentage practice in the rural areas. So that diffuses that idea of, oh, we need it to be able to expand. But it is coming, and the system I work for, Ascension, and is made it point blank. We are going to have 2 NPs for every 1 physician. That is that's how it's going to be. And if you're a physician that comes in conflict and you want to leave, we love you, we mean it, goodbye. But we've got 2 other waiting for you that we can pay. And the reality of it is, the next step is, insurance providers have never said, you know what, we think you guys do just as good of a job, and so we're going to pay you the same. No. Once the volume is there, it's, well, you all were charging this, but we're going to loop you all as providers, and now the pay for providers is going to be this amount, and it's not going to go up. Ours are going to go down. That's just the way insurance works. And so, the other thing that's I wanted to mention, because, I oversee some nurse practitioners in mine because of somebody has to do it in our system because they're there, and a lot of them are very, very good providers. Some of them are excellent providers, so I'm not denigrating them at all. But what I'm seeing that's tragic is the nurse practitioner schools are popping up. They require almost nothing for a college to say, we have a nurse practitioner program. And so I have nurse practitioners that rotate with me. Almost all of them were somebody is a friend of a cousin that says they aren't going to be able to graduate or they have nowhere to go. They are not required to provide them any type of residency or placement, and they claim that they will be able to help them. And then when comes time to do their rotation, they say, here's a list, call them. And a lot of them are other nurse practitioners who charge them $1,000 a month to come and do this. Now, the school is still charging $40,000 a year, but providing nothing for them. It's a travesty. And as I said, that's kind of their problem. But I think it speaks to the bigger issue of training. And I think there should be an expose done on the lack of the fly-by-night, nurse practitioner schools that are sprouting up, because that will help to require at least a base statement that will decrease this escalation that we're seeing, because they're not held to the same standard. When DCOM was developed, it couldn't even think about coming together until they could show that they had places for preceptorship and for to be able to train. They couldn't do it. Nurse practitioner programs require nothing. They basically say, here's some places you might want to call, or they might have some suggestions, but that's it. So that's also something I think we need to look at. But the arguments for when you talk to your representatives are, we have nothing against nurse practitioners per se. It's just they need direction. They need to be part of a team and not independent. It's not needed because they don't go to the places that they say they do, and they cost the system more because they haven't enough training to feel comfortable in their medical decision making.
With the training that he just alluded to, how nurse practitioner training is getting less, and physicians, I feel like it's more and more restrictions and more. So that leads me into, I had written down about the longitudinal boards. A couple of us have discussed some of that. I don't know how many of you have gone on to that path now of research with the longitudinal boards. I've found it pretty confusing, much more difficult, much more time intensive, really not cheaper, actually a lot more expensive. And then, the thing that frustrates me too is that, they say, well, these modules you have to do, you get 5 CME credits. So I guess that cost is kind of offset, but it's forcing me to do CME through those specific organizations, which is frustrating because I'd like to choose my own CME. So those are just some frustrations I've had. And then just some difficulty with some of the questioning and things like that too. Anyone else have experience or issues or anything they want to go over on that?
Just a small comment. I don't like it either. And I don't like how with the tests that we've always done on the computer system, you can go back. So it's little things like that. If you like misclick something or something like that, it's not very user friendly.
And then I don't know how many of you have done it or, you know, or looked into it, but you have to get 8 out of 10 questions right, and there's no going back. And once you confirm it's in, and I've actually found some errors, and I know there's people who found some errors, and we've brought it up to the board. But you know, if you don't get that 8 out of 10 right, then you have to remediate and finish it all by the end of the year. And so, and then just kind of some confusion about what is all involved, and you don't really know until you're in it, kind of thing. Yeah.
I was going to go to a different topic. Okay. So in line with my concern for the doctor-patient relationship, the medical community worked in the past to lobby for a clean claim to be paid in Tennessee briskly, and they do that now. I would be glad to serve on a committee that has to do with insurance and the headache of the prior authorization process and the rules that we're held by if we participate with insurance, to where you're almost doomed by the timelines that they give you. So I'm all in on insurance, and many of my colleagues here are not, and I love talking with y'all. You don't take insurance, and it's not a headache for you, and I applaud that. But for those of us who are part of that game, because it is a game, I would be glad to work on that.
This is in response to Michelle's comments. I became aware of what she just told you 2 nights ago when your leadership, your president and your president-elect and myself and Dr. Whiting took the AOA president to dinner. And she had mentioned that the day before, and I'd not heard that. I spoke to another person today about that. Now, I will tell you what has happened, and when the executive director of the AOA was here, was that today? Yesterday, I don't know what day it is. She had the opportunity, Michelle had the opportunity to talk to her about that because she's in charge of all of the administrative work that we have. I will tell you that this will be an issue that I'm taking back to the AOA board because I am still on it for another 4 months. And we created this issue with the continuous certification in an effort to make it less onerous. So in 7 years, you panic for 2 years prior to that test that you've got to take and know everything that you knew when you finished your residency. So the idea was to make it more convenient and cost effective. And if it's not doing that, I can assure you we will, and I'm speaking AOA right now, we will fix that because that's why we did it. And we worked on this over many years and getting every specialty, osteopathic specialty organization to concur and to convert. And there's lots of issues that I've been able to pick up very briefly from this. But my point is, only reason that I'm going to be doing that is because that's the first comment that I've ever heard about it. You need to let your representatives, you need to let your new president know what your concerns are here in the state, because this is the organization that has protected the practice of osteopathic medicine in this state. Our licensure board has been in existence since 1902 or something like that, and we're independent. We're one of 13 states that still have separate licensure. We have an excellent licensure board, and we've maintained we have high respect in the Department of Health, or whatever it's called officially, with the way that we handle issues that come with respect to licensure. But we have representatives there, and they can talk about, they write the rules that say what you can, they bring them up and get them approved, what you can and can't do in this state. So we have control. We don't want to get rid of that. But the point is, reach out to someone who can get your issue, if it's really a significant issue, to the right person. And we will do that.
Thanks. I guess I should probably speak to that since, yeah, I was fortunate enough to get to do the longitudinal board last year, probably like one of the first people in the state, I guess. So, yeah, it was a little bit confusing trying to get started. It was very expensive, I agree. When I actually was doing the questions, I was a little disappointed in the quality of some. Some were so complicated that I felt like I was just like, making a guess at the right answer. And then others were so easy, I was like, I think, pretty much any first-year medical student could probably get those. There were also some typographical errors in the question stems. One question was actually wrong. The answer was wrong. And so I emailed AOA, and I was like, look, I need to point this out. I'm 99.99% sure that your answer is wrong, and I got this right. I got a nice response back shortly, and they were like, we're so sorry, you're right. Your answer was correct, and we had the wrong answer actually documented on there. So that was just kind of one example, and so I'm like, well, this needs to be corrected. They assured me they would throw the question out for not just myself, but everyone else who had done it. But by the time I finished in my fourth, quarter, it was still not thrown out, so my score still reflected that I had passed, but the question had not been thrown out. So some small things. Obviously, anytime there's change that occurs to this extent, there's going to be bumps in the road. So I guess what I'm looking for is to see how these bumps are held, like fixed. If they have really good maintenance and they're going to take care of this, then we might be able to adapt, and this might be a good solution. But agreed, it's very frustrating. I thought that it was longitudinal, meaning that every quarter I would be doing more questions. So the January to March quarter, I logged in, and I was like, oh, I can't log in. So, I sent an email, and they were like, oh, you don't have an account anymore. And I'm like, well, I guess that means I'm board certified. I got a certificate in the mail, so great. But I haven't done questions this quarter, so I don't know. But that's what we are going to work on. And like Dr. Ely said, we spoke with Dr. Gelb about this, and so I will be more proactive, in communicating with the AOA moving forward to try to make sure we kind of get this resolved, and that I have more answers for you guys. So if things come up, I had given you guys my cell phone number earlier. Please let me know kind of what experiences you guys are having, because it'll be helpful for me not to just take my experience and Michelle's back, but to have multiple other perspectives, okay? So, yes, we will definitely be working on that, and I think they're going to be receptive. It's just the communication, we have to work on that a little bit. Oh, yeah. Sorry, so, yeah, the new longitudinal board is basically you have 10 questions every quarter, but you only have to do 3 quarters unless you don't get an 80% or better for one of the quarters, in which case you have to remediate that quarter in the 4th quarter. So, correct. It's for your board certification. It's to replace the board exam, the high-stakes board exam. And then you have to do modules that, yeah, they cost, was it $500? I didn't remember how much they cost. I blacked out when I paid that. But, in the modules, yeah. I mean, I think most of you would breeze through them without even listening to the information in the modules. So they were pretty easy. I felt like I'd like a little bit more complicated stuff, at least to teach me some more stuff. But, yeah, so we will work on this, but it's to replace the high-stakes exam is essentially what this is. So, well, our understanding is that it was constant. So every single year you would do 10 questions every quarter. Oh, yeah, so apparently I haven't done the questions for last quarter. Awesome. You may not want me as your president anymore, guys. But one last thing. So I wanted to talk to that, and then to Dan's point, there is a PA committee that's already been formed with the TMA. I don't know if you knew about that. I get emails, but I would love for you to take over on that. And again, kind of all of us working together. I just have not had time, but I get an email periodically, and they're like, "Hey, come to our meeting." And I was like, I didn't have time, but so I will get you all that information because absolutely, as someone else who takes insurance companies, all insurance, it's very frustrating. So.
Yeah, I don't want to beat a dead horse. I had the same questions, and just a little horror story. Hopefully, it didn't happen to anybody but me. So I was supposed to recertify for my big high-stakes boards in 2020. Got postponed. You have no option to take it, so I had to wait till 2021 because of COVID. Then you can't go to a test center. You have to do it online. I don't know. Did anybody else have to do the online board thing? No, you did. So I was like, oh, this is going to be great. I'll be sitting there in my own office, and I can take this test and everything, and I don't have all the pressure logging in and put your fingerprint and all this stuff. It was horrific. So real quick, because hopefully we won't have to do this going forward. I don't know if it's an option now or not, but that's my second point. So anyway, I go in. You have to clear everything out of your office. So I did it at my work, and that was like my housekeeper thought I had quit because she's like, "Why? What is going on with your desk?" And so you have to take pictures of the whole room. You have to do all this stuff. You have to have a camera set up. So I followed all the rules. Get in there. It took forever to log on. It was jittery and jumping around and everything. And I'm already nervous taking a test, sweating and stuff, and then the person's right there looking at you while you're doing it. I'm like, this is really weird. Anyway, I forgot how many questions it is. I think 180 or something like that. I had 10 questions left and it shut down. And so the moderator comes on and they're texting, they type you back and forth. They kept saying, move your camera, do this and that and the other. And they're like, sorry, something messed up. We got to reset your test. I'm like, no, please don't do that. Please don't do that. They're like, no problem. We're going to reset it and you can pick up where you left off. Screen went blank, all this kind of stuff or whatever. It was on a Saturday. I'm taking it. They're like, don't leave or you're going to have to redo this test. So I sat there for 4 hours. I called everybody I could call, but of course nobody answered or whatever. I emailed every board person I could at the ABOF, whatever. And anyway, never got an answer other than we realized it was a problem. We're going to apply for you to retake it. So then I was like, well, that's good, I guess. So then I get a nastygram email that says, you're going to take it on this date, which was like 7 or 10 days later. If you don't, that is your only chance to remediate. I'm like, I didn't remediate. I only had 10 questions left. Well, come on. And so that's what I did. And so that time, I'm telling you, talking about being nervous, I'm like, this thing's going to shut down. This thing's going to shut down. I'm like, click, 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 click. So fortunately, I passed it. Well, then next thing I know, I get put in the longitudinal automatically, even though I just took the big board test. Oh, wow. So then I emailed everybody I could, and I still to this day have no answer back. I called, emailed, and everything like that. I didn't call you. I thought about it, but I didn't want to bother you. But so yeah, I guess all of a sudden I get this email saying, hey, it's the end of March. You haven't answered these questions. You need to do it. I'm like, okay, well, I guess this is my only choice. So then I paid the money, and you have to wait and everything, and you do it or whatever. And then so I guess we just do it now forever, and we don't have a choice.
That's what I've been told, but it's
Yeah.
still, again, very confusing. I asked her to update the website and just be much more clear because it really, you go in there and it's like, this is what you're supposed to do, but it really doesn't even say. Like
It
you
doesn't,
said,
yeah.
Yes, you do this every year. Yes, it's the modules every year. Yes,
Yeah.
like it's really.
Well, and hopefully you brought up the point the other day that the transparency and the a real person answering the phone, that was brought up the other day. I mean, hopefully that happens because, like I said, of course, that day was a Saturday, and nobody's going to answer the phone. But I did that for the next week. I mean, I called everybody, Chicago, and everybody left messages. I never got a human to call me back. Pretty scary.
Yeah.
So hopefully that won't happen to anybody else.
Yeah.
Yeah, I mean, it sounds like I'm not the only one that didn't know about these changes, but like I have my board certification through the family practice boards. I feel like I should have had a lot more information made available to me about this. Last time I did my high stakes, you know, it was like, oh, I noticed like my stuff's gonna run out kind of soon. I need to sign up, and I go to sign up, and they're like, no, you're too late to sign up for that now. I'm like, but I'm like, no, you're just gonna expire. I'm like, oh, okay, that's sweet. What can I do? They're like, yeah, nothing. You can't do anything. You'll just be expired for a while. You know, if my AOA membership's gonna run out, I get letter after letter. The color starts to change. Everything changes. I get like one letter from the family practice boards at one time, maybe, that's like, you know, you're gonna expire at some point. I'm like, this is ridiculous. This is absolutely insane. And of course now, like, lots of insurances, if you're not board certified, they can't take you. And you know, it was supposed to be like, oh, I'm going above and beyond, and now it's like another just access to care. Like, you can't be on insurance if you don't have your board certification, and it's just all very frustrating.
Anybody else? I think we hit on a lot of good topics. This was fun for our first town hall. Maybe in Nashville we can talk about inviting some legislatures and do this again. That would be great, because next year our convention's in Nashville, so that'd be perfect. So we'll start working on some of that too.